Okay, it is 8:01 this morning. Welcome to AHI New Mexico, and we do have Janice Whitlock. Privileged to have her presenting today. I'm going to go over our slides here real quick so we can get right to our presentation. So welcome to Envision New Mexico Studio Envision. And just to remind you, we are recording this session, so please don't include any confidential patient health information in any discussion. Also, because of the high turnout today, we are going to be doing a chat-only comments and questions. So if you have any issues, please send me a chat. I'll be monitoring that, and Jeannie will be monitoring as well for any questions or comments. And we'll go ahead and relay those as time permits. We'll be doing roll call here in just a few minutes, or in just a moment. What we're going to do also, roll call will also be through the chat box. I'll send you another chat so it pops up for you or starts blinking at you in case you can't find it. And just click on that and let us know who you are and where you're from, and we'll get you written down for your CME certificate. Actually, the video and audio does not apply today because we're not having everybody on video because of our high turnout. And thank you all for coming. Our disclosure and accreditation statements are on screen now. We do offer, we have a partnership with Molina and Blue Cross Blue Shield New Mexico Centennial Care. You can be reimbursed by those entities if you bring your case consultations to us. It's a big part of Adolescent Health Initiative New Mexico. And we are having our, I believe, our final case consultation session next week. So if you haven't done that for the initiative for your certificate, please get those in. Contact Michelle Widener, you can contact me, you can contact Jeannie, and we'll get you all the information you need. And we do have our asynchronous online telehealth training sessions on a platform called Moodle. The best way to go about that is to go to our website, go to online training, and fill out the form. Select AHI New Mexico at the bottom of the screen, hit submit, and you'll get all the information you need from there. So if you're not able to attend all of our sessions this semester or last semester, you can access them there for a half a CME, as well as credit for the certificate. And at this point, we're going to go ahead and have you chat in and let us know who you are, where you're from, and we'll take roll call that way. And I suppose at this point, I'll turn it over to Jeannie Dalen, and we can go around the room and introduce ourselves here at Studio Envision.
Great. Welcome. Good morning, everyone. This is Jeannie Dalen, clinical psychologist at UNM Pediatrics. We have an excellent, wonderful presentation, and I'm so happy to see the turnout in the cyber world. Before I introduce our speaker for this morning, let's go ahead and go around the room and let you know who's with us in the Envision studios this morning.
Hi, my name is Maya Trujillo. I'm a quality improvement specialist with Envision.
My name is Danielle Chang. I'm a UNM Pediatric resident. Andrea Anderson, a QI specialist here at Envision.
And with that, I'd love to introduce this morning Dr. Janice Whitlock, who is the director of the Cornell Research Program on Self-Injury and Recovery. She actually spoke with us last year on this topic of self-injury, suicidal self-injury, and it was such a wonderful turnout, and people loved the topic so much that we actually asked for an encore, and Dr. Whitlock was wonderful enough to oblige, and so we'd like to welcome her. She'll be giving her presentation at Cornell, and on her side of it. So again, as Kevin mentioned, because we have such a great turnout, Kevin and I will be monitoring the chat box, and as questions come up, we will at some point in the talk go ahead and get those questions as we can. So with that, Dr. Whitlock, welcome. Thank you for being here this morning, and we look forward to this morning's presentation.
Thank you so much. All right, let me just find my slides again. Oh, they're there. And I will be fully present as I can be. So I just wanted to let everybody know that I'm home today. I just have a cold, so I decided to do my work from home today. So I've asked everybody in my home to be very quiet, but if you hear noise on my side, it's probably my 19-year-old daughter who is home from college this week and who didn't get her text. So thank you guys so much for inviting me back to talk about self-injury. I'm pretty much going to summarize what I did last year because it seemed like that was the kind of information everybody wanted. So as I understand it, we'll have time to take questions via chat at the end. Is that correct? All right, so for today, my goals are fairly straightforward. I want to give a little bit of background, including definition and taxonomy, basic prevalence and function, as well as talk some about the common presentation in adolescence. So with that, by that I mean sort of forms and locations on the body that it tends to occur, the risk factors that tend to precede it or go along with it, including comorbidity with other mental health challenges. And in particular, relationship to suicidality, because this is something that I know everybody knows always comes up, and self-injury has an interesting, somewhat paradoxical relationship to suicide that is important to note. And then we'll finish up with some detection and intervention, and one of the basic models that we use in working with schools and other institutions for sort of thinking about it. It'll be very intuitive for everybody because it's a very sensible model, and I'm sure it's applied in many forms already in the institutions and worlds you work in. And then some common treatment approaches and the key components of those approaches and resources. I have to tell you, it is always weird for me to do a webinar because it is so odd to just be talking to a blank screen. So I'm sort of happy that you guys are down there in the corner box. I can see you. So say hi once in a while, okay? So a little bit of background. So non-suicidal self-injury is defined as the deliberate, direct, and self-inflicted destruction of body tissue, resulting in immediate tissue damage for purposes that are not socially sanctioned and without suicidal intent. So believe it or not, that definition took about a year of work among a small group of scholars in 2006 and 2007, to come up with, because there's a lot of different things that we had to consider, largely, especially at that time, because deliberate self-harm is a concept that's used in the UK and includes suicide, but it was pretty clear by then that, at least within the studies that were happening here in the United States early in the millennium, that we were starting to see a phenomenon that may look like suicide, but wasn't undertaken without, which was undertaken without suicidal intent. So that's why that's there. Non-suicidal self-injury lacks suicidal intent by definition. And for purposes not socially sanctioned, is really intended to exclude things like tattooing and piercing or any kind of behavior that can look like self-injury, but that is undertaken for aesthetic purposes, or that there's a significant social group that sanctions it for some reason. So, so in this case, it's what we have in mind is tattooing and piercing is excluded. However, I will say that there are a number of studies that include tattooing and piercing, and it is pretty clear that excessive tattooing and piercing can serve some similar function as non-suicidal self-injury. So there can be overlap in those populations. So one of the biggest questions that's come up over time is why worry about it? Isn't this something that just people will age out of, and it's sort of a bracketed of lesser order in terms of how worried we should be about a spectrum, all the spectrums of kinds of things that can go along with it. Why this one? Well, there's a few answers to that. It is pretty clear at this point that NSSI is a harbinger of other more lethal conditions. It's a pretty strong, it can be a pretty strong indicator of potential suicidality. So it's basically, I think of it as kind of a canary in the coal mine. If it's showing up, then it's a fairly visible evidence that there's underlying distress that might increase risk for suicide and or other really chronic conditions. So it's just definitely something to kind of tag as there's distress that's accumulating, it's being acted out on the body, and it's likely to be this distress, unregulated distress is likely to be showing up in other ways and may actually culminate in suicidality and things that are going to be much harder to treat. It can cause unintended severe injury. In fact, in a good chunk of cases, I think it's close to 30% of people who chronically self-injure say that at some point they injured themselves much more severely than they intended to. So that means it's interesting about that too, because they will often cut deeper than they expected to cut, really need to be seen by a physician, so that often require stitches, but it's very, very small minority of people who will actually go get the assistance they need. They end up, I've heard just crazy stories about what people will end up doing to try to take care of a wound. So So that is something that happens and is, in terms of implications for treatment intervention, one of the things we'll get to is it's really important for everybody to know that people really should be trained on how to take care of themselves and how to reach out and get help when they need it. It can lead to lasting disfiguration. I promise I won't stop and tell stories all the way along, but I will tell you this one. One of the first, I didn't know anything about self-injury in 2003 and 4, and I finished my dissertation on connectedness and thriving. I really wanted to know and still study what is it that schools and communities and families can do to help people really thrive. But it was because it came into my life personally through friends of my family, and in particular one young woman who was 15 at the time who was cutting, and I got very curious about it, and it started this whole research program now, been 15 years almost. I recently saw her a few years ago, and one of the things that she told me that I had never really thought about is that of all the things that was going on for her when she was 15, and she's now like 25, she could hide everything except this one. And this one had a lot of implications for her life because she now worked in a geriatric day treatment center and for older folks, and she wanted to be able to keep that job. She loved that job, wanted to do more in it, but she had to wear long sleeves all the time because she had scars all over her body, and she was afraid that she wouldn't know what to say to them when they asked her why. I'm so sorry. And she was afraid that her boss would find out and think that she would be, it would be harmful for her to work with older people. So this is something that's come up a few times, and it's not something people tend to think about. I think I'm going to have to get some water. If you could just pardon me for 1 minute, okay?
So this is Jeannie at Envision as Dr. Whitlock gets some water. Just for those of you who joined late, she's joining us from her house and has a cold this morning. So we're so happy she was still able to do this talk. So we'll let her take a second to get some water.
Oh man, I really don't feel radically sick, but it has settled in my chest. So here we are. Anyway, so it can be contagious. It does tend to sweep through schools and institutions, as probably some of you already know. And it's really stressful for people who love and or live with someone who self-injures, especially chronically. All right, so in terms of how we think about it in context, it's really useful, I think, to understand that self-harm, as all of us know, kind of can run the gamut from very low lethal behaviors to much higher lethal behaviors, and non-suicidal self-injury is just in there. So we tend to think of this continuum of direct and indirect self-harm. And direct self-harm would be things like suicide attempt, major self-injury, which is not something I'm going to be talking a lot about today, but is part of the continuum, which would be self-inoculation and auto-castration. Atypical self-injury is sort of mutilation of the face, eyes, breast, genitals, or multiple sutures. Not things we see a lot. But usually if you see these, just FYI, if you're seeing this in any of your populations, it's usually a sign of psychosis or other kinds of really significant psychiatric disorders. So especially if it shows up in a school or community context, it's important to get treatment right away. And then the more common forms of self-injury, which is where we're going to focus most of our time today. And indirect self-harm includes a lot of things, but the most common are substance abuse, eating disorders, unhealthy risk-taking, use or misuse of prescription drugs, and then there's a variety of other things that I know we could all think about would fall in that continuum. So if you have a client who's got a number of things, it's pretty likely that the common forms of self-injury may not be the primary focal point for treatment, especially at the beginning. Things like eating disorders may actually be much more severe in some cases, or drug use or really severe unhealthy risk-taking. So it's always useful to really think about what's the context, what else is going on, and where does self-injury fit in, especially if you've got a client that you're working with for treatment, because it really may not be that it's the most important thing to target. But it does, there's a few things I know about people who who self-injure when they show up. I typically will assume that somebody who's, when I see self-injury, I will typically assume that I'm working with somebody who's really exquisitely sensitive emotionally. Excuse me one second. You guys. And that they have an issue articulating emotion and regulating emotion. So we're going to talk a little bit about that in a little more detail in a little bit. Okay, so these are just sort of basically in another form what I had just shown you. And in terms of non-suicidal self-injury, it's these three pieces right here, the major self-injury, atypical self-injury, and common forms of self-injury that are typically included in that part of the continuum. Like I said, we're mostly going to talk about the common forms, but major self-injury and atypical self-injury do occur, especially in some of the populations that have more risk factors and more trauma history. All right, so within common NSSI, there are basically three types. There's relatively low life, there's the superficial injury, and I'm sharing this because it's pretty clear that these three basic taxonomies or categories of self-injury say a lot about how worried someone should be or how much of a target the self-injury behavior should be in terms of treatment and intervention. So there have been multiple studies now, and all of them really converge on three classifications. And they tend to run this way. So superficial can be, they're people that have relatively low lifetime self-injury frequency, and they use really few forms of self-injury, resulting in pretty superficial tissue damage, like wound interference or scratching. So the big question here is, what's the worst possible case scenario in this kind of, with this kind of form of self-injury? Could somebody can't usually end up inadvertently taking their life by scratching, for example. So that would be the superficial classification. And that group of people tend to have higher than average, they have higher risk of suicidality and other disorders when compared to people who don't injure, but they're the sort of the lowest risk category among people who do self-injure. And then there's this battery-like tissue damage group that tend to have low frequency overall, but they use several forms of self-injury, that the worst of which results in moderate tissue damage, which we would consider like bruising or small punctures. What's interesting about this class is that 64% of all self-injurious males tend to fall in this group because it includes hitting and punching. And we're going to talk about forms in just a minute, so I'll get back to that. But it's generally of shorter duration than the other classes. Whereas the other classes, especially the third class I'm going to talk about, can go on for quite a few years. This tends to resolve sometimes without any kind of treatment in 2 to 3 years. And then the chronic high severity injury class is the one probably all of us associate most strongly with the classic cutter stereotype. So these are people who have high lifetime frequency. They use several forms resulting in severe tissue damage. And so the cutting is in there. Burning the tissue, really intense punctures, or embedding, kinds of things that really could inadvertently result in death. They're most likely of all the groups to conform to sort of the classic stereotype, so they tend to have routines that they could tell you about. They get habituated, which is the word for avoiding the use of the word addiction, because it's not clear whether or not something like self-injury can be considered addictive, except that it's pretty clear it can be a process addiction. So they're most likely to say that they can have their urge to injure independent of any other stimulus. So they can be sitting in a classroom, no trigger happens, but they have a very strong urge to injure. They're much more likely to hurt more than intended, and they're more likely than anybody else to perceive that it's interfering with their life. So this group is about 70% female and 30% male. And it's probably the one you see most often. It's probably the one you worry about the most often. And it is, in fact, the one that has the highest correlation and association with suicidality and other comorbid conditions like eating disorders. All right, so in terms of prevalence, what we know is that there's lots of studies now. So when we started this research in 2004, I think is when I started the program, there were very, very few studies. It's one of the reasons we started the studies. And we started at epidemiology because there was not a single reliable study out there at all, not in the United States, not anywhere, that gave us a prevalence estimate. And I remember vividly when we had to make the estimates, because we were trying to figure out how much power we needed to detect self-injury and some of the other analyses we were going to want to do. I think we estimated about 5% of the population, in this case it was a study for college populations, would ever have self-injured. Well, I was shocked in 2006 when we ran the study. It was a really well-designed study, and we had a random representative sample. We had all sorts of checks and balances built in to make sure we weren't getting bogus data. And we found a prevalence rate of 17%. And that was in Cornell and Princeton students, mind you. So since then, there have been a whole range of studies with lots of different populations, and we're all pretty much converging around 20%. So lifetime prevalent estimate ranges from 7 to 25.6%. Although I will tell you, there was a few studies that were done that showed, 50 to 60% of adolescent populations will say that they injure. A lot of it depends on the methodology that they use. But that can be up to 65, or even in a more recent study, 85% of clinical populations. A recent review that was a meta-analysis of all the studies that are out there now shows a point prevalence rate of about 17.2% among adolescents, 13% among young adults, and 5.5% among adults. These were a meta-analysis of studies that were both within the United States and outside of the United States. So this is actually an international prevalence rates estimates. And oddly, the prevalence rates don't vary very much internationally or even regionally. We're just not seeing the kind of variation we expected to see at all. I would say I'm most comfortable saying that in most secondary school populations, in most states in the US, you're probably looking at 20 to 25% of your kids have ever self-injured. But that's not, ever self-injuring can include one time and it can include 900 times, so it's important to kind of break that down. What we find in most of the studies is that about 25% of the people who report ever self-injuring is a single time, and the rest of them is repeat. So if the question is how many of the kids on your school campus are walking around chronically injuring in some way to manage emotion, I would say probably 6 to 10%, give or take a few percent. Probably on the upward end, not the downward end. It's not at this point, I don't think it's going to be less than 6% are current and repeat. And I can't remember if I say this later, so I'll say it here, which is most people who injure are episodic injurers. It's not like they start injuring and then that's their thing and they do it every day or weekly or whatever for years. It doesn't really go like that. It tends to go in and out of cycles. And those cycles contract to all sorts of things going on in the outside world, like with, variations in important relationships or transitions and things like that. But if somebody who hasn't injured in a few months but who has a history of using injury to manage emotions is at high likelihood of injuring again. I've run into a lot of people who thought they were done and they really are not done. So it's kind of important to know about the cyclical nature of things. In terms of demographics, what's also very interesting is we expected, there was a lot of expectation in the early studies that we were going to find this was very much female, maybe it was primarily Caucasian, maybe it was primarily upper middle class or upper middle class, that it would sort of look like eating disorders looked in the early days. Didn't find that at all. Nobody's found that. So in general, what we find is females are slightly more likely to injure than males, but only in some studies. There's an equal number of studies that find a totally 50-50 split. Very few studies find males more likely than females. So if there's going to be a gender difference, it's going to be slightly more females. But again, it's 65% female, say 35% male. The one area where we find consistent, let me back up just a minute. So there's a gender difference. We find no socioeconomic status differences at all, not even close. Racial differences are sometimes come out, but they're very, very modest, and they always wash out really early when we're starting to factor everything in. So there's not real big patterns there. The one place where there's a really big difference is sexual orientation. So consistently, what we find is that the people who are more likely so people who on the middle of when we look at sexual orientation as a Kinsian scale, so we don't ask people necessarily to self-identify sexual orientation, but we ask them, say, who are you sexually attracted to or aroused by? People in the middle of that scale that say that it's sort of equal males, females, or slightly skewed one or the other direction, male or female, but still kind of mixed in the middle, are much, much more likely to be at risk for self-injury than any other group. And interestingly, there's a big gender split there. So it's particularly women in the middle of that range. So there's a lot of research being done right now on why that is and what would help to explain it. Because some of the simple theories about minority stress theory, for example, doesn't explain the gender divide at all. You'd expect it to be both males and females in the middle of the range, when in fact it really is largely females. So there's often a link there. It's strong enough that if among all the women in the middle of that range, 50% of them will say that they have self-injury history. So that's the one demographic correlate that seems to really make a difference in terms of prediction. Okay, so if we were together, we would stop here and take questions, and I would breathe and take water, but since we are not in front of my screen, I'm going to just pause and take a drink of water, and then I will tell you why. Okay, so in terms of why, which is what everybody wants to know, these are the things that people say. And again, this is really consistent. Now I'm going to show you sort of groups of categories of ideas that come out of multiple studies, and the parentheses, the parenthetical percentages in here are in the last big study we did of all the people who said they injured, what percentage of them endorsed that particular one. So in general, at this point, it's pretty clear that if self-injury ever ends up in the DSM, this piece to regulate negative affect or no affect, and affect is feeling, so basically or emotion, to regulate emotions, will be part of the definition of one of the criteria for self-injury, because it shows up everywhere. So pretty much everybody who injures regularly has an affect regulation component to it. And we now understand a little bit more about why, and I'll tell you about that in a sec. So that's the dominant reason. People also, though, talk about social communication and belonging. For a lot of people, there's a connectedness component to it, sort of a solicitation of connectedness, or to express some form of hurt or noticing. Some people will talk about self-punishment and deterrence. So either they want to avoid committing suicide, or they want to atone for what they consider sins or things that they've done wrong. And then we also see sensation seeking or self-distraction. Self-distraction is another form of coping. You just don't want to have to think about something you don't want to think about, so I'll do this instead. But what's interesting to me about the sensation seeking is that you don't see anybody endorsing any of these items until they've injured at least, I think it's like 6 to 11 times in their life. So this is partly, I'm interested in this because it seems to be really linked to the idea that one of the reasons self-injury becomes such an adopted and easy to turn to behavior is because it engages the endogenous opioid system. So, we're all these walking chemical factories. We don't think about that, but we all know how to modify our mood states. I mean, we'll probably get off here and go get some coffee or tea or something like that, or chocolate. But self-injury functionally does the same thing. There's a way in which it engages sort of the physiology or our physiology in order to increase it. For some people, endogenous opioids. So these kinds of endorsement of these kinds of items very much speak to that. But it's not the reason people start. It does seem to be one of the reasons that it can be maintained, however. Okay, so I'm going to tell you the neurological piece that sort of started to emerge in the last few years. That is, when I first heard Joe Franklin talk about this in 2012 at a conference I was at, it was one of those moments you just don't have very often, but they're like, oh, this makes so much more sense to me. So here's what we're finding about why neurologically self-injury might work. So this is, before I tell you about this, we got to understand a couple of things. And some of you might remember way back when we started to talk about brains and the way that brains behave, control behavior, that there was this idea that there were certain parts of the brain that governed certain things. Like there was a particular part of my brain that governed my ability to see or to hear or to smell, that kind of thing. Well, we know now that that's not really the way it works. We know that we're more a little bit like the Matrix. We have more of a matrix up there than we have particular locations. And while there are some location dominance around some things, it's all connected to everything. And that, even more interestingly, the circuit boards that are established for one purpose can be redeployed, meaning they are established, they can be used for multiple purposes. Actually, the very same neural networks that are governing my smell, for example, can also be giving me information about the color of the sky. I'm making that up, so don't quote me on that. I'm just saying there can be very different things that they're processing at the very same time. And that was really an amazing thing for people to discover. So one neural circuit can basically serve multiple functions, and they can be really general and very, very different. So in the case of the self-injury phenomenon, there were some studies early on looking at two parts of the brain, or two sort of networked parts of the brain, called the anterior cingulate cortex and the anterior insula. And I remember some of the early studies had nothing to do with self-injury. They were looking at whether that old adage, sticks and stones will break my bones, but words will never hurt me, was true. And in fact, it's not. Actually, it turns out that the brain regions associated with, the neural networks associated with pain, physical pain, are less, they light up less, they're less aroused than emotional pain. It turns out that it's the emotional pain that's really causes the intense physiological and emotional reaction that we have. That was very interesting. And that set of research started this domino effect of trying to figure out how everything is related. So in the self-injury story, these two pieces of the brain end up being really important. And they do two things at the same time that's important for us. One is they process physical perceptions of stimuli. So I pick up my glass of water, I've got my hand on it. Right now it's telling me it's cool, but it's not too cold, it's not too hot, it's fine, I can keep it in my hand. That same brain region, that exact same part of me that's processing that, is also trying desperately to give me information about whether or not you guys like me. It's processing my sense of emotional connection to people out there. So it ends up, the fact that those two processes are happening, seemingly very distinct, are happening at the same time in the same place, leads to some really odd things. Like, found out that holding a warm cup of coffee when you meet somebody new tends to increase the likelihood of describing that person as warm, because it's the same networks, which I was like really amazing. So I always tell my students, if you go for an interview for a job you really want, well, bring some warm coffee or cider or something. Because the thing is the people that are holding the warm cup of coffee have no idea that the warmth of that coffee is actually feeding into their assessment of the emotional reaction of the person, their assessment of the person in front of them emotionally. So there's this overlap between social and physical pain, basically. And this is where the self-injury study came to be, the self-injury piece comes in. So what it turns out, let me just say this first. The second generation of studies said things like, well, if that's the case, then does medication that's targeted for the brain regions that reduce pain perception, which is Tylenol, ibuprofen targets inflammation, not this brain region. Will that also affect emotional arousal? And the answer is yes. So I'm not advocating Tylenol, please know that. I'm just saying that it is really interesting that turns out you can take Tylenol if you're feeling emotionally rejected and feel better, if you have the patience to wait the 30 minutes or so that it takes the Tylenol to kick in. So it turns out that targeting those areas for, say, Tylenol leads to decreases in perceived social and emotional pain because they're the same brain regions. The thing that one quick and easy intervention is holding hands also reduces the AI-ACC activity and reduces both physical and emotional pain perception. So let me just say the upshot here. The upshot is that for self-injury, it looks like part of what's happening is that somebody becomes emotionally aroused, especially if it's the rejection-based arousal, which is a major trigger for people who feel like people who injure, is this perception of being rejected. They're likely to overinterpret things or to differently interpret things or more negatively interpret things. So they are very emotionally aroused up here, and they really, really, really don't want that feeling, and I can't blame them. It's not a good feeling. And they don't know how to bring that arousal down of the ACC-AI. It turns out that when somebody cuts themselves or hurts themselves, there's this peak pain moment, but then there's this pain offset. Because doesn't just feel the same acuity of pain, it eventually will drop off, usually within a few minutes. Because the exact same brain regions are working on both of these, once the physical pain offset starts to come down, it brings the emotional pain down with it. Does that make sense? Okay, let's see you. You guys in the room say, okay, good. That was huge when I was like, oh, that makes perfect sense. And wow, what a quick and easy and clever way to bring down arousal. So physical pain spills over into emotional social pain, and physical pain relief spills over into emotional social pain relief. And for people who injure, they tend to have brains that are more, they tend to have sensory systems that are more acutely attuned to emotional cues. And you can see this neurologically, actually. They tend to respond very strongly to even subtle emotional cues. So I always tell people, it's kind of like a gift. You have a gift. You're very emotionally perceptive. But it's also a burden because they often have no idea what to really do with that. But it turns out that this process of self-injuring and then having it come down the other side helps them to it feels big. It's not small. It's not a small offset. It's like a major relief. So the highs are higher and the offset is more intense than a person who doesn't function that way. And it's really important to note that this coupling they're using a natural, normal, universal system. We all have this. Why it works so well for these individual people is probably mostly because they're very perceptive, and the pain offset feels very much like a relief. So once I got this, it made self-injury make so much more sense to me, and it makes it easy to understand why people have a hard time walking away from it, because it's a very quick and fast way to move from a state of high arousal or a state of intense dissociation into a state of calm or integration really, really fast. Like it can happen within 30, 40, 50 seconds or less. So that's the why. So in terms of common presentation, these are the things in this order that we're most likely to see. So severely scratching or pinching and with fingernails or other objects until bleeding occurs, or cutting. Those, depending on the study, those will be in first or second place, but those are the two most common kinds of behaviors. Banging or punching objects to the point of bruising or bleeding with the overt intention of hurting the self. That's important to note. And then banging or punching oneself to the point of bruising or bleeding with the overt intention of hurting the self. These are important because they look like external focused aggression, and not surprisingly, guys are a little more likely than girls to do this. But the person, in this case, people know that part of what they're after is that the pain offset. It's just that the rest of the world doesn't see that. And mostly we don't ask about it, and we don't treat it as self-injury. We treat it as aggression. Biting to the point that bleeding occurs or deep marks remain on the some ripping or tearing skin, pulling out hair, eyelashes, or eyebrows with the overt intention of hurting the self. I know this gets, some aspect of this can be OCD, but again, that people often, if they're using it for self-injury, they know that the pain is what they're after. Intentionally preventing wounds from healing, burning, embedding is what it's called, so rubbing things into the skin. And there are more. These are just the most common. There's got at least 17 different behaviors that people do. The most common locations are here in this order. I'm just going to bring these all up. So arms, wrists, hands, thighs, stomach, calves, and ankle are what people report the most commonly. But honestly, it's everywhere. I've never met a body part that hasn't been used as a place for self-injury. In general, if people are injuring on their face, their genitals, or their breasts, there's usually other more severe psychiatric disorders at play. So those are the kinds of things that should trigger a really quick response and referral into psychiatric care. It's not, it's pretty much I'd say that's mostly the case. I'm thinking of a couple of cases where it wasn't exactly like that, but in general, that's what happens. So I would mark that as being something that should trigger immediate referral. A few other things to note. Most report injuring in private, but some do injure as part of a group membership or ritual. So it's really important to assess the extent of group engagement. We particularly see this in schools, where people will say sometimes that they have groups of people who will do it mostly off campus, and then they'll come to school with sort of matching room places. But we've also heard of cases in which people injure at school in a group, and most concerningly, they will sometimes share blades, which brings a whole other host of issues because of blood, mixing of blood and other fluids. So it's really important to assess whether or not other people are involved, or if there's a group component to things. As I said earlier, it's often episodic. I wouldn't assume people are out of the risk zone, even if there's a long lapse since the last injury episode. It's really common for people to go months, sometimes years between episodes. It's good to assess periodically. It can become habitual or addictive for about a third of individuals. It's most common in that sort of the high severity group. So you might want to assess degree of entrenchment and then use harm reduction models as needed. It's really tough for someone to go from regular dependence on self-injury to nothing. They won't do it. It just isn't going to happen. People don't stop injuring until they're really ready to, and it usually takes a fair bit of weaning off and learning to deal with that emotion another way. Because remember, with the pain offset, sort of the neurological piece I just covered, it's such a fast, quick route to a place of calm that it's tough to walk away from. And they really definitely usually need to acquire a variety of different skills. They need to practice when they're not triggered, and they need to understand why it works for them. There's just a lot of processes that have to happen before they'll walk away. About 20% of individuals who self-injure report doing so more severely than they intended. We already talked a bit about that. So really, but this becomes really important. Like, you really do want to assess whether or not this has ever happened and what they did when that happened. So for example, one of my earliest interviews was somebody who injured her belly. Often it's a belly that gets the brunt of the hardest injury, I think, because the skin is softer there than they're used to. But she cut her belly, and she realized she'd gone too deep, and she sewed herself up with her mother's upholstery thread. Because part of what happens is people become very ashamed that they did that they got out of control, and then they're much less likely to seek help. So I would ask whether that's ever happened, what they did to treat it, and then make sure they know basic first aid and self-care. They probably do, but just be sure. And then maybe talk about a strategy for dealing with this should it happen, or should it happen again in the cases where it's happened before, like a care plan or a safety contract or something that will make it more likely that they'll actually get physical treatment. I just talked about that. So primary risk factors are, in a lot of ways, this question of like why self-injury is not something we can completely answer yet, although I think we're getting closer. Because a lot of the risk factors are risk factors for everything that you all deal with. I mean, they're the same risk factors for eating disorders and other issues. So the two things I really want to point out here are the second one, individuals with a history of emotion dysregulation or sensitivity. So these are often individuals high in emotion detection, but low in emotion regulation. And they tend toward a negative cognitive style and some degree of rumination. So those are the two things that really seem to be kind of not unique, but there's something in that alchemy right there that that when you mix it with having the pain offset work really well for them, that makes self-injury, that them at particularly high risk. History of trauma and abuse and neglect is there, but I got to tell you, there's a whole bunch of people, maybe upwards toward 40%, who really don't have a history of any of those things that also self-injury who also self-injure because it's become such a common thing. But I do try to tell, especially if I'm working with parents, about this emotion sensitivity can feel like such a burden, but it really is something that people can often really leverage into a gift if they can learn how to work with it. So so it's something, parents want hope. People want hope to work with, and it really can become a gift over time. So associated in clinical samples with all of these things, I'd say, it's associated with everything. It's one of the primary criteria for borderline personality disorder, as some of you know, but it's also associated with everything else. I'd say the highest comorbidities with disordered eating. So 25% of people who injure will have a disordered eating issue at some point, and vice versa. They're not usually at the same time. They usually kind of go back and forth. There's a moderate association with sexual risk-taking, alcohol use, or non-prescription medical drug use, but lower than we thought. It's actually much more comorbid with other mental health conditions than other risk behaviors. It was added to the DSM-5 as a condition in need of additional research, and it's likely to be added to the next DSM iteration. So one of the biggest questions that always comes up is, it looks like suicide, it feels like suicide, but you're telling me it has nothing to do with suicide. So I have this little diagram for my tree for helping us to understand that self-injury and suicidality share a lot of risk factors. All of those things plus some are the kinds of risk factors that are present for people with suicidality too. So these are just a few on the bottom of the graphs. The childhood trauma might be there. The physiological sensitivity is kind of the neurological sensitivity I was talking about, the emotion sensitivity. Maybe there was some exposure or receptivity to self-injury through media, through friends or family. But whatever it is, there's a certain alchemy of things that kind of lead to vulnerability. And then it meets life, which can be tough, especially if development itself, being a teenager itself, is a risk factor because of the neurological changes that are happening. And that can really lead to distress or a sense of having an overwhelming amount of emotion I don't know what to do with. And that comes together with I don't know what to do that works, and that can give rise to self-injury and obviously a whole bunch of other stuff, but for us, self-injury. So the question then becomes, well, when do we really worry, and who are the people who are most likely to be suicidal? So what we figured out is that in general, this is what you expect. Over time, you tend to see, and we're talking about community populations of kids that don't have a whole bunch of other psychiatric risk factors in this particular case. This is going to be slightly different. Like the people who go on to this left branch, the resolution and healthy coping, will probably be smaller among highly clinical populations. But in general, in community populations, 35 to 40% of people over time will stop injuring. They will learn how to deal with emotion in functional ways, and they will go on and have a healthy, happy, normal life. There's some number that will just continue going up the middle of the tree. That'll be what, 20 to 30% will use self-injury, or they'll switch off with other kinds of negative or adverse coping techniques, and that will do that for a long time, sometimes well into adulthood. And then there's the folks on the right who will move into suicidality. And those are, that's the group we all really, really worry about, because of course we don't want that to happen. So who are those people? Well, we don't know. It's interesting. There's been a lot of studies now that are trying to figure that out. So we know a few things. We know that self-injury and suicidal behavior are overlapping in the sense that it's not uncommon for someone who uses NSSI to also have suicide ideation. And it's not uncommon for people who self-injure for a while to become suicidal. And 35 to 40% of people who have self-injury who use self-injury will be suicidal at some point. And then there's like the rest of them won't ever even think about it. So that's important, right? if we ask, like, well, what predicts this right branch? The answer is less clear than we'd like it to be. So there's been multiple studies now, and the predictors are a little bit slim. So in the study we did a few years ago, this is what we found. The risk of moving to suicide from self-injury was predicted by over 20 self-injury incidents over time, a low sense of meaning in life, which makes sense. And what was really interesting to me is poor relationship with parents, because we put part of that variable was relationships with everybody, therapists, adults in your life, family members, friends. There was a whole bunch of people, but the one group of people who really, really kept showing up over and over again in the analysis were parents. They're really, really important. And that showed up not just in this analysis, but in other analysis and other studies. And it was so prominent a feature that I now have a whole wing of our research devoted specifically to family, particularly family interactions in recovery. So it's, take home for me here has been, even if family has been important in contributing to the onset or maintenance of self-injury, they seem to be really, really important in the recovery process. So if you can get them to, it's not always possible, and they're not always, sometimes they're so toxic that it's not recommended. But if you can engage them, it's clear they really matter. And self-injury doesn't lead to suicide. It's really, really clear, but it does lower inhibition. So meaning that if somebody has self-injury experience and they become suicidal, it's easier for them to conceptualize it and to enact it, because they've already learned how to literally and figuratively sort of slice through the various personal and social prohibitions that we all feel, inhibitions we feel around, damaging ourselves. They already know how to do that. They won't use if they're suicidal, they won't use their self-injury technique though. That's usually not what happens. It's usually, they have a whole nother method, because their self-injury comes from, and this is important, the self-injury comes from developmentally understandable and healthy desire to feel better. It does not come from a desire to end life. So their method, let's say it's cutting, is really trying to help them feel better. That's important. Okay.
Dr. Whitlock?
Yes.
Hi, I'm sorry. I just wanted to remind us as we're coming to the near the end of the hour. We have about 6 minutes, but this is such a great topic. So we just wanted to see, would you be willing to stay a few minutes at the end for questions? Because I'm assuming we might have a lot of comments and questions coming up.
Sure. I was just going to ask you, how are we doing on time? Because I know
Yeah, we have about 6 minutes, so enough to go through some few more slides, and then I bet we can go to questions then.
Okay, I'm sorry about that.
No, this is wonderful. This is a great presentation. Thank you.
Okay. Oh, you're welcome. Sorry, it's off. Okay, so in terms of detection intervention, so you guys will all have the slides, and I will tell you right now that we have a lot of resources on our website. So if you just Google self-injury in Cornell, you'll pull up our website, and there's tons of resources there. So please find things there, and you'll have access to all this. So these, I'm just going to populate this real quickly. These are basically the ways people find out. There's a lot you can do it. Somebody can tell you, you can hear from someone else, or you can observe it. In terms of detection, you're probably, if you see it, it's likely to be fresh. You're probably going to see either fresh wounds, unexplained or clustered scars or marks, maybe blood, odd unexplained paraphernalia, and frequent bandages or wristbands are really common. The indirect are a little trickier. They're the constant use of wristbands or bracelets, which go in out of style. The biggest indirect detection method I know of is inappropriate dress for season. So people who wear long sleeves or pants when it's warm outside, and in New Mexico, that is a lot of the year. So that's a real telltale sign to me that there's something they don't want people to see. And then unwillingness to participate in events, association with peer groups who injure, or chronic mood swings or moodiness, which of course predicts most everything. Our model basically says this: just respond, and we'll talk quickly about that, assess it, engage whenever possible with the young person. You really, really want to approach them as an ally, as a collaborator, as you really want to engage them in the process of making whatever decisions have to be made that they can make within your system, because they often don't feel like they have a lot of agency or control. Education, and then referral. So responding is the really important part. We advise people use what we call respectful curiosity, which is basically a stance. It's a consciousness with which you meet it. It's the idea of responding non-judgmentally, immediately, and directly. So you don't want to avoid shock or emotional displays if possible. Try not to minimize it or ignore it, and do assure rapid attention and assessment, and suicide assessment is indicated. So it could be something like this. Sarah, I noticed the cuts on your arms just now. It looks like you might be cutting. Usually people do this to feel better when they have feelings they don't want or like. Is that happening for you? So it's compassionate, it's direct, and it's respectful. Or I understand that it may be hard for you to share your feelings. This can be a hard thing to talk about. How about if you and I go talk to the guidance counselor together about what you're feeling? I'm sure we can come up with good ways to help. Same thing. It's compassionate, it's direct, it's respectful. There's key elements are focusing on the feelings rather than the behavior, remaining calm and dispassionate, using respectful curiosity, which is asking questions that help you get information, like, help me understand why you do this. I love starting a sentence with, help me understand. Help me understand. Can you help me understand? Because that implies that it's me that needs to understand, not that they're doing something that's terribly not understandable. How does self-injury help you? Who do you feel comfortable talking to about what you're feeling? And just be clear about what has to happen next and provide choices whenever possible. So I know, so I'm going to refer you, rather than go through this, I'm going to refer you to Barry Walsh's book on treating self-injury, A Practical Guide. This is all his biopsychosocial model of assessment is in there, along with some great assessment tools. And the other person I'll refer you to for the treatment people out there is Matthew Seligman. It's Selekman. He's got a variety of treatment guides that are fabulous. And he focuses not just on like trigger logs, but also on epiphany journals and your positive trigger logs. When you didn't self-injure, what is it that happened that allowed you to stop? Like, so he has people direct their attention to when they're successful and the things that they're learning about themselves that ultimately are going to lead to the motivation and the discipline to do the things they need to do to stop. So you also want to assess indications of recency, chronicity. This is the patterning, the lethality, because that gives you information about how worried to be, and number of forms used, because in general, the higher the lethality, the higher the number of forms used, and the more common they do this, they're in the higher class categories. It's one of the first things I ask are these things, these last two in particular, and lifetime incidents, because I can pretty much classify people really quickly right away in terms of, okay, what am I looking at? How worried should I be? You want to engage point people on staff or in the community. Ideally, the person who self-injures and any supportive peers, especially if there's contagion at play, and family. Determine whether self-injury is frequent or high lethality, quality, or protocol warrants parental notification. I mean, everybody does this differently, and institutions have different guidelines, but I think the treatment or the community I work with, self-injury, has pretty much that we've all navigated toward more parental involvement rather than less, because everybody's finding that parents matter so much. And then educate. It really helps people who injure to understand, especially the neurological piece. It helps them to understand themselves, because they often feel really out of control and weird. And it helps them to know that they're probably sensitive, because it feels validating, and it helps them to understand why they might quickly do this and why it might work so well. And then I think understanding just opens up more space for considering options around, do I really want to continue doing this? And then refer. So in terms of treatment approaches, these are the most common treatment approaches right now. The ones on the treatment modality side on the left-hand side, and there's their focus, but I want to just come here to the core components, so I don't want to run out of time. Basically, the things that seem to really be the most effective pieces of the treatments that are working is working with emotion literacy, so helping them to understand emotion, and I'm going to come back to that one second. Working with negative cognitions and self-regard, because that's really a huge piece. They tend to have low aversion to blood and pain. They tend to not mind that. So working around that a little bit. Increasing the ability to tolerate distress, increasing a lot of the mindfulness movements are helping people come present and get out of the stories that they might be entertaining that are triggering them, because people can self-trigger. I'm sure we've all had that happen. You just start thinking about something that happened and suddenly you're in an emotional state, even though it's a gorgeous day outside and nothing's happening right now. So learning to come right back in to the present moment is tough, but usually very, very, very helpful. And for people who injure, if they can sit through it or go for a walk for 15 minutes, if that once the urge comes on, if they can not do anything, just not do it, not self-injure for 15 minutes, they're usually the urge will drop off. So that's learning how to be through that period is important. So one thing I want to say around that emotion that's fascinating, it looks like the more recent studies are showing that people who injure are very, very comfortable with negative emotion. They don't have problems with negative emotion. So working around negative emotion, like understanding when it comes up is important, but where they really struggle with emotion is the whole other part of the emotional spectrum that's the positive emotion. They are very often resistant to allowing in positive feelings. So in terms of treatment intervention, it's really helpful to help them, if something good happens, to say, hey, can you just let yourself have a good feeling for just a minute, like just 1 minute or 30 seconds. Because that's the challenge they have. They really understand the topography of negative emotion. They're really uncomfortable in the positive emotion realm. So, and in order to down regulate without having to injure, they're going to have to learn how to allow in the positive stuff, which takes time. So that's been a really interesting shift that's showing up in the literature recently. And then they really need to practice skills in untriggered environments. Most important thing I can say there. Okay, resources on our website. We have training on there. You can go there and find it. I think I'm done. I'll just go back.
Excellent. Thank you, Dr. Whitlock. It looks like we have a question from Deborah Hill. She's interested in knowing more about what you were mentioning, the harm reduction models.
So the harm reduction model as a concept is rather than focusing on, stopping, you focus on, well, what's one step you are willing to take? So if somebody, for example, the harm reduction model in the self-injury world would be, so you've been using a blade to injure, would you consider using a blunt object to rub across the skin instead next time? Can you try that? Or you tend to have a particular kind of response to an emotion. Would you practice another kind of response? Maybe you can, instead of injuring, you can practice getting up and walking around a few minutes before you injure, just to practice. So it's not going for you're not going for the whole enchilada here. You're not saying you got to move from injuring a lot to never injuring. You're saying what small steps can you take in recognition that it's usually a path that may take a fair bit of time. It comes from, the harm reduction models come from treatment and sexual risk taking, but it applies here.
Great, thank you. This was a fabulous presentation. Again, as always, it was, we're getting comments this, thank you, great and helpful information. Thank you so much for providing such important information. I think it's a topic that it's insidious and we know about it and that it exists, but it's been difficult to get excellent information on how to think about it and what the prevalence is. So this was wonderful. So we really appreciate it. Would it be okay if anyone does have any further comments or questions that they could just directly contact you to get some information on? Wonderful.
I am leaving at the end of this week for a week, and I will not be bringing my computer at all. So
Good.
That's like yes.
Well, we really appreciate your time, especially because we know you're not feeling 100% today. But thank you again. This was wonderful.
Thank you. Have a great day, everybody.
And thanks to everyone for joining us. Again, as Kevin mentioned, our case consultation, last one, will be next week. So if anyone needs assistance with that endeavor, please feel free to email Kevin, Michelle, or myself, and we'll see you next week, same time, same place. And again, everyone's saying how helpful this was. All right, everyone, have a great week.
Bye. Bye-bye.
Bye.